Okay, good afternoon or good morning, depending on where you are. This is Jeff Ades. I'm here today with Sandy Jensen. We are doing a presentation today on telehealth as it relates specifically to FQHCs. Some of you may have listened. Our firm has given a number of COVID-related presentations earlier this week, and all the information in those was very important and continues to be important. What we're going to try to do today is specifically focus on FQHCs because, unfortunately, many of the rules that apply to pretty much all other providers do not apply to FQHCs, or FQHCs are treated differently. Let me just start off by saying that, because we always get this question, we are recording the session. We will be sending out a recording. We'll be sending out all the slides. So you don't need to sit and be taking pictures of slides. For those of you who have listened to me before, you know that what's necessarily on the slides is not really what I'm saying a lot of the time. So I try to present it. We give you the slides. They have all the information. We try to present it in a plain English way so that you can follow. We are going to be covering a number of topics today relating to COVID and relating to telehealth. Some of the topics that we will cover will be what is telehealth, what kind of systems can you use for telehealth, what are the HIPAA concerns with regard to telehealth, what are the HRSA concerns and limitations regarding to telehealth, and what things has HRSA waived relating to it. And then we will get into reimbursement. Obviously, we have many attendees who are in many different states, so we are not going to be able to address reimbursement in every single state. We will be focusing, giving you some examples more specific from New York and New Jersey, and then we have some slides that address many other states as well with regard to telehealth. But I will say with a caveat that these rules are changing on a daily basis. So, for example, in New York, the rules changed last week on Thursday, then changed again this week on Monday and Tuesday, 3 different sets of rules each day. So we are going to give you the most current information that we have, with the understanding that this may change again by Monday. I will also mention that you may have heard that federal government passed a new law late last night, which has some impact on many of the COVID-related issues. It does not seem to have much impact on the telehealth-related issues, but because it happened last night, we do not have all the updated information. We will, to the extent that we are able to provide additional information. I will also mention that on Monday, we are doing another presentation that relates specifically to your role as employer and the new FMLA leave and all the other different benefits that are available from the federal government to employers, because we understand that many of you are in a financial crisis right now and are having to lay off people. I've spent most of my week this week dealing with either layoffs or telehealth, and it's been a terrible week all around for everybody. So we will be addressing some of that on Monday. I will also mention, I'll mention this again at the end, that we are doing a separate webinar on Tuesday relating generally to your FTCA application. As we go through the presentation, you'll hear that many laws have been suspended, or there's been some flexibility with regard to them during this period in the interest of trying to treat patients. For whatever reason, HRSA has determined that the application is due in May and will remain due in May. And we posed the question to them this week saying, you got to be kidding. People are really trying to save lives now, and having to deal with FTCA applications should not be a high priority. and their response back to us was that they are not extending the date, and the date will stay the same. So unfortunately, at least as of now, subject to someone being able to lobby and change them, and we have reached out to various organizations to try to get them to change it, but as of now, they are not moving on it. So you unfortunately will need to move forward with your FTCA application. So we are doing a separate session on Tuesday for that. Okay, with that, I'm going to turn it over to Sandy to walk through some of the requirements of telehealth.
Okay, great. Hello, everyone. We just wanted to start it off, with the very basic, what is telehealth? And HRSA defines telehealth as the use of electronic information technologies to support and promote long-distance clinical care for patients, education, and public health and health administration. The definition also varies depending on your state and payer source. They can really require a certain kind of electronic communication. Let's see. So pre-COVID, telehealth generally required an audio-visual real-time platform, and that means that you can see the person through some sort of platform. Most are through an app, and you can hear them in real time so that you could have a conversation. And again, that was pre-COVID-19. States generally did not allow telephone only or email only communications. They wanted, the real time back and forth audio visual. The Office of Civil Rights, ever mindful of HIPAA concerns, prohibited use of certain platforms like FaceTime and at one time your general Skype, where the developer would not sign a BAA or a business associate agreement with the provider that would ensure that, any PHI that was shared on the platform was secure. And if you did use one of these platforms that the provider, the developer didn't sign a BAA with you for, then the Office of Civil Rights could enforce violations of it, because on your end, you have to make sure whatever kind of platform you use is secure. As a result of the emergency, as you know, everyone's trying to loosen up their standards to make provision of health services to patients as easy as possible, and to the extent possible, keep people at home and allow you to do services remotely. So on March 17th, the Office of Civil Rights issued this notice, and this is the full notice, and you'll get the slides and you can review it at your convenience. And basically what it said was that for the short term and during this emergency only, that the Office of Civil Rights would not bring enforcement actions against you if you use a telemedicine platform that didn't comply with HIPAA. So all of those requirements that you use, only platforms where the vendor would sign a BAA with you, that's all out the door. You can go ahead and use certain platforms that where the vendor is not going to sign a BAA with you, as long as they're not public facing. And I'll explain what that is in a little bit. They also went a step further, and they say, let's say you use one of these platforms that isn't necessarily 1,000% secure. The vendor didn't sign a BAA with you, and as a result, there was some access to PHI. As long as you are making a good faith effort to provide, reasonably private connection, you're using, with respect to this emergency, you're making good faith effort to provide this service, and there is a breach, they're not going to pursue penalties for breaches related to this emergency. So they specified that providers can't use public-facing platforms. And these platforms are designed to be open to the public or allowed a wide range of people to access it. And they've listed some that are public-facing. And they issued guidance later on to further describe what public-facing is. And They gave an as example, a provider uses FaceTime Live to stream a presentation to their patients. I'm sorry, excuse me. So a provider uses FaceTime Live to stream a presentation available to your patients about the risks of COVID-19. They're saying this is a public-facing platform. You're opening it up to a wide range of people. People can communicate back and forth, and it's not a reasonably private provision of services to your patients. And this would not be covered by their notice. They say you should not disclose any PHI or provide any individualized advice during this live stream because it's not protected, and then it would be subject to enforcement actions. Okay, I think I'm going to turn it back to you, Jeff.
Sure. Okay, so some other rules that HRSA has passed. I'm sorry. Okay, so like Sandy just said, yes, we are better off using the things like Skype and Zoom. But we want to talk about some other things that HRSA has passed. So to the extent that you don't see it, there are haven't seen it, there are FAQs that HRSA posts relating specifically to COVID, and they update it on a periodic basis, and there are a number of things that they included in there that we want to spend a couple of minutes talking to you about. Okay, so HRSA, as you all know from dealing with the government, right? HRSA deals with the regulations that apply to FQHCs, but not with the reimbursement. And as you all know from dealing with the government, the right hand doesn't necessarily talk to the left hand. So there's been a lot of relaxation on some of the rules, but not necessarily as it relates to reimbursement. So we're just going to go through some of the rules. I would say that the basic gist of what we want to get across in the next few minutes, and we'll give you some detail around it, but the basic gist we want to get across is taking care of patients is most important in this time, and worrying about things like QA and risk management and other back office type things that you do become a little bit less important, and there's some more flexibility in terms of being able to do things, which HRSA has acknowledged on some level. We are talking about federal, but I will mention at state level as well. Many states have suspended or modified many of the rules that apply. So, for example, in many states, if you have a practitioner who can practice for you, I'll just pick, you're in Louisiana and you have a doctor who's there who's only licensed in Kansas, right? Historically, the Kansas doctor would not be able to practice in Louisiana. So in many states, they've now waived it and said as long as the doctor is licensed in any state, they can go ahead and practice in this state because we have a shortage of doctors. They've also, again, in some states, relaxed the rules relating to supervision of physician assistants, supervision of nurse practitioners or APNs, and they are allowing, again, more flexibility with regard to that. Like I said, we can't go through today every single state because different states are different, but you should be checking because many states have established that kind of flexibility. We also note that Sandy mentioned that the OCR has said you can use all these platforms. Technically, many states have confidentiality rules where the state needs to follow along with that waiver, because if OCR says that you can use Skype and Texas says you can't use Skype, well, you're now technically violating what's going on in Texas. I am not giving advice to the many attendees across the board that you can rely on, but our experience has been that in most of the states, they are following the federal rules and are allowing you, for example, to use Skype or Zoom or something like that for your telehealth session. Also, importantly, because we've gotten this question on many occasions in the last week, at least in any state that I've seen, and again, I can't tell you this in every state, but at least in any state that I've seen, the rules relating to telehealth that have been expanded do not relate solely to patients who have the virus or you suspect have the virus. So if you can do telehealth, you can do telehealth even for a patient who otherwise is healthy and is not calling with, those kinds of conditions where you're worried they have the virus or they actually do. You can still use telehealth for that. However, what I said about being able to use people who are not licensed, in many states, the expansion to allow a non-licensed person or a non-supervised person to provide services is limited to virus-related services. So, for example, in New Jersey, right, you can use telehealth for any patient. However, you can only have a Connecticut doctor practicing in New Jersey to be able to treat patients who have the virus and not to treat other patients. So you need to be mindful when you're crossing over in terms of normal licensure rules. Those typically are limited to treatment of the virus, whereas telehealth rules tend to be across the board, not only limited to the virus. Okay, so one of the things that comes up, right, obviously that comes up for an FQHC, and again, like I say, we have a lot of different slides here. I'm going to talk about it generically, and then we'll get to some of the specific words, is what do I do now? Is FTCA going to cover telehealth at all? And is FTCA going to cover, if my doctor is sitting at home and not sitting in the FQHC, or the patient is sitting at home, what are the rules around that? As well as what makes a person a patient for FTCA. So we're going to go through the details, and Sandy's going to walk you through some more of the details, but I'll just tell you that very high level, FTCA does apply to telehealth, and as long as you have a provider, FQHC patient relationship, you will have FTCA coverage, assuming that the service you're providing, now that means the underlying service, is included in your scope. So for example, if you in your scope you have primary care, you can do telehealth for primary care. If you now want to do telehealth for cardiology and cardiology is not in your scope, you can't go ahead and use telehealth because HRSA goes back to look at what is the underlying service being provided by telehealth rather than at treating telehealth as a separate type of service, right? So you're not going back to your Form 5A and adding telehealth. Telehealth is just a means of developing a service that is on your Form 5A. Okay, one of the other things that also comes up and is addressed on this slide is, so a patient is calling, they are not a historical patient. They have not been there before, and they're calling now because they can't find any other doctor. They know that you're treating this, and so they're calling you for it. So HRSA has clarified that speaking to the person through phone or through telehealth will qualify the person as being a HRSA patient, being an FQHC patient for purpose of telehealth and allow the coverage as long as either they were previously a patient or they're calling for the purpose of becoming a patient. So in those cases, you would be covered. Now, we mentioned telephone here. Telephone, we're going to get to this a little bit later, but telehealth and telephone are different for a lot of purposes, particularly for reimbursement purposes. Telehealth means audio-visual, right? You're seeing the patient while you're talking to them. Telephone, obviously, is just talking to the person without seeing them. So the rules in many states are very different. In most states right now, you still only are being reimbursed for telehealth, not for telephone. There are some states like New York where you can be reimbursed for telephone and you can provide services through telephone. For FTCA purposes, it seems like for triage purposes, they are expanding it to include telephone as well. So you might have, you're doing a telephone conference with a patient calling in to ask about, their symptoms. You could be covered for that under FTCA, although you may not be able to bill for that service because it doesn't meet the telehealth definition for billing purposes. Okay, so like I mentioned, there's three three categories you need to have here in order to be able to do it. What the service you need to be providing is on your Form 5A. So pediatrics is on your Form 5A, that's okay. If you're doing some kind of specialty that's not on your Form 5A, right, you're bringing an infectious diseases person now because that's something you're worried about. If that is not on your Form 5A, you will not be covered under FTCA for it, and you have to submit a change of scope to add infectious diseases or cardiology in my prior example to your Form 5A in order to be able to do it. Okay, so that's criteria number one. Criteria number two is the clinician providing the service has to be a health center provider. That means that they are either employed or contracted. Well, so let's say they're employed. If they're employed, you have FTCA. If they're contracted, we fall back to the general FTCA rules, which basically says that if they're in primary care and you have a direct contract with them, they'll be covered under FTCA. If they are not in primary, if you have a contract through their entity, through a hospital, they will not be covered under FTCA, but you still will be covered under FTCA as long as you're employed. And if they're a specialty service, they generally, even if it's a direct contract with them under a 1099, they will not be covered unless they're working at least 32 hours a week. If they're working 32 hours a week, they probably should be an employee, not a contractor. That's a separate conversation. Okay, but then the person has to be a health center patient, like I mentioned, and it could be that they're becoming a patient now through this visit. Okay, so like I said, it could be individuals who have not presented for care, never been to your health center, never been a patient before, but they're calling for a telehealth visit, and they're being treated by your provider. Now, importantly, and we'll get to this a little bit more later, you need to document, right? So there has been, and rightfully so, there has been this mad rush this week in terms of trying to set up telehealth in your centers and trying to teach doctors how to use telehealth and trying to teach patients how to use telehealth and trying to deal with all of that. And one of the things we've seen is people are forgetting to document. If you don't document a visit, then you don't have a visit and you don't have FTCA for that visit because you never had the visit. So it is important to remember to document. Now, the documentation, as the slide later talks about, is a little bit looser, but only a little bit looser. You still need to have the basics of a visit set forth in your EMR in order for it to qualify as a visit, for you to be able to bill what you can bill, and for you to be able to qualify for FTCA. Okay. So HRSA did also clarify, and I'm jumping a little bit, and I'm going to jump back, because one of the things that we're hearing is, okay, so I'm being asked to help out in other circumstances, or my service area is in this zip code, but there's no one in the next zip code, and patients from there are calling. I typically do not include them. And so what HRSA has said is that if a patient is in your service area, that's where you should be focusing. But if there are service areas outside of yours, and you are going to provide services via telehealth. Now, this is not in person. We'll deal separately with in person. But if you're doing it via telehealth to people outside your service area who are becoming your patients, you can include that and you will be covered under FTCA. However, the word that HRSA is used is occasional. They have not defined what occasional is. So I can't give you any definitive answers. What I would tell you is that if still, 75 to 85% of your visits are going to be patients in your service area and you have a handful that are outside, I think you probably fall into the okay on the occasional. Okay. So I want to talk for a minute about the dollars, right? So hopefully all of you who are at least full FQHCs, right, because lookalikes have not gotten any of the grant dollars, received some dollars. I'm going to use the word some very loosely, right? You got $50,000 plus 50 cents for every patient listed in the UDS, plus $2.50 for every uninsured patient in the UDS. So what we've seen is most FQHCs receive someplace between $60,000 and $100,000, which, as many FQHCs said to me this week, is nice, but is not really going to do much for you if you are not going to have any, if you're right, if your patients, if you're down 70% in volume, which is the number we keep hearing, right? Most of our clients who we've spoken to are down someplace between 50 and 80% already in volume in areas where the virus has hit significantly. And so giving me $70,000 is not really going to do much for me. On the other hand, you did use it, you did get it, and you can use it for anything relating to providing services. You also can use other things. If you had other things that were bought using federal funds, you can use them towards telehealth as well. There has been some talk about being supplemental dollars available, but they have not yet provided the details. Another question that we've gotten, and unfortunately I will say that I'm not extremely happy with the answer that HRSA has provided, is, okay, so let's say we assume this thing is going to last 2 or 3 months. Can I go ahead and pull down more of my grant dollars than I typically would pull down? And then, in November, I'll worry about November, but I need the dollars now. So HRSA has kind of given a non-answer saying, you have to think about it, you have to worry about your budget and blah, blah, blah. But at the end of the day, what they're saying is you're still subject to the rules that when you pull down the dollars, you have to use them within 72 hours. So you might be able to pull down some extra dollars to help cover your payroll, but you cannot pull down dollars to use for other operational purposes unless that's what you've been using your dollars for before, or unless you're going to start recording and complying with all the procurement rules, which you normally would not need to if you're just doing it for wages and you're complying with your wage and hour requirement. Okay, so at this point, I think, Sandy, you were going to take back over?
Yeah, sure. So we also wanted to make you aware of a telehealth PAL that was issued by HRSA in January, the end of January. So this was issued before the emergency was declared. And after the emergency was declared, as Jeff had mentioned, a lot of the telehealth rules were eased to make it easier for you. So just keep in mind that the guidelines and the requirements in this telehealth PAL are important, but they've been changed a little bit by the emergency response. So you should definitely check out the emergency response resources on HRSA's website. And then, if you intend on continuing telehealth, then the guidelines in this PAL. So just briefly, we'll go through it. As Jeff has said, telehealth is not a service or service delivery method that you have to request approval from HRSA. It's just a means for delivering a health service to patients. So it's just like a face-to-face visit that you're authorized to do. You're just using electronic technology to do it. You don't have to separately record use of telehealth on the Form 5A. Again, it's not a new service. It's just a way of doing it. And what they really encourage is having written policies on how your facility will use telehealth. And it includes such topics as licensing, scope of practice, privacy, confidentiality, and patient consent. And you really have to look at your payer requirements as well, because I know here in New York, Medicaid has a bunch of requirements in their guidelines on how they expect telehealth to be provided, and it includes privacy and confidentiality and patient consent. So the PAL lists out, where services could be provided, sites, and different scenarios that they would consider in-scope services. And so for services, again, they have to be listed on your Form 5A, and anything listed on your Form 5A can be provided through telehealth. And they clarified that supportive activities like taking vital signs or operating a monitor that you need to have done by clinical staff to facilitate or make that telehealth visit happen are considered within scope. With respect to sites, locations where all of those conditions are met are determined to be, within approved sites, even when received by telehealth. And these are, your health center visits are documented in patient records, providers exercise independent judgment, services are provided on a regularly scheduled basis. But locations where all services are only provided through telehealth would not meet these requirements. So you can't just move to an all telehealth system. You have to still maintain your physical location, but then you can provide services in some way through telehealth as well. They also list out a chart of scenarios that they would consider within the health center scope of project. And I just wanted to point one out to you because this is really helpful when we're not in an emergency, but where the patient is at their home and the health center provider is delivering services from the health center service site. So as long as certain requirements are met, that they would consider that within scope and that would be covered. However, remember that this was issued before the emergency was declared, and so these requirements are loosened, and now the provider can be in their home as well. The patient and provider can both be in their home. So moving on to FTCA coverage, and Jeff was mentioning this as well. We're just reminded that the way to obtain FTCA coverage really hasn't changed. The provider must be a covered individual, so that's an employee in very, very limited situations. They could be a qualified contractor. They must be providing covered activities, and that's with actions within the scope of deemed employment. You're only covered for medical, surgical, dental, or related functions in site services or other activities or locations within the health center. The health center provider, the person that's rendering the service, must be acting within the health center's approved scope of project and within their deemed employment. They have to be acting on behalf of the health center. And when we have to be mindful of this, because when we have some of our providers volunteering for other organizations, it might get tricky on who are they working on behalf of. And for activities to be considered within the health center scope of projects, they, as Jeff was saying, they have to be documented and billed as such and perform consistent with standards. So just some additional considerations that are applicable now for volunteers, and this was part of the guidance issued by HRSA on the emergency response. So that you can get FTCA coverage for your volunteers, but they're not automatically eligible. Just because they're acting on your behalf, they won't be automatically eligible. You have to apply for them to be covered under the FTCA through a deeming sponsorship application, and each volunteer has to individually be granted deemed status. So if you have a volunteer, John Smith, you would apply for John Smith to be deemed covered under the FTCA. It wouldn't be a blanket application for all of your volunteers. With respect to non-patients, Jeff had covered it before, and the rules are relaxed to allow coverage for services provided to non-patients. And as I had mentioned previously, you have to be really careful when your providers are volunteering or providing services at another facility or health center. You have to really look, because the FTCA may not cover it if it's unclear in what capacity they're providing services when the issue or the liability event came up. Did it fall within the scope of employment of your health center? Were they working on behalf of your health center when they provided the service? Okay, Jeff, I think so.
Yeah, so I'm going to jump back in. I just want to mention we had originally put this up for 45 minutes. We actually have it scheduled on our end for an hour, so to the extent that people could stay on, we probably will go beyond the 45 minutes. Also, because we keep getting this question, we get it every webinar, so I'll just repeat. The webinar is being recorded, and the recording and the slides will be sent out. We also understand that a couple of people are having technical problems getting on. I would tell you to try to get on, because we currently have 193 people on, so it is working. We apologize for whatever reason some people are not able to get on, but you might want to try doing it again. If you know of anyone who can't get on, or one of the people who are emailing or texting me, you could try to do that because it is working. And we've had people log off and log back on, and it has worked for them. Okay, so one of the other things I want to talk about globally is sites. So there's two issues that have come up now. One is that, right, in most places, at least again where the virus has spread, dental services, as an example, have been shut down. So we're not providing dental. Or we don't have enough patients, or we don't have enough staff, more likely, because our staff has gotten sick, and we usually have 6 sites, and now we need to go down to only 3 sites because we can't staff 6 sites. Or we need to expand because either there is an area near us where people can't get services, or our building, we can't be in our building for whatever reason, so we want to set up a tent, or we want to set up a mobile van, we want to set up some other basis to be able to provide the services. Or we're a school-based center and the school is closed, and so now we can't see people in the school, and we want to set something else up instead. So I will tell you as a global rule, if you are closing a site or closing a service for the duration of the virus, you're doing it for a short-term period, you do not need to go back to HRSA and get approval. You do not need to do a change of scope to take it out of your scope. I would encourage you not to do a change of scope to take it out, because you take it out and then later on you want to put it back in, you have to go through a whole process to put it back in. So I would not be doing anything right now, and HRSA has clarified you do not need to do anything in terms of taking it out of your scope. If you want to have temporary sites, so there are rules about that. Basically, you need to give 15 days notice to HRSA if you're setting up an additional site. That actually means a physical site. If you're using a van, using some other method of providing the service, you do not need to go back and get the approval. However, you need to just keep in mind that you need to comply with whatever state rules as well if your state has not waived their rules. I will tell you that I just want to point something out, and my hope is that the payers are going to be flexible about it and are not going to make an issue out of it. But sometimes, I'll say on a managed care level, right, if you have a site and you end up not providing any service from that site for 3 months and no doctor working from that site, no provider working from that site, your contract could theoretically be terminated because they didn't see any activity from that site. I will tell you that, in certain states, the state has addressed this and advised insurers that they cannot do it. If that has not happened in your state, you might want to reach out to someone in your state and try to get that taken care of, because you just don't want to be in a situation where when you come out of this, now you have to start re-credentialing with the payers for it. Okay. With regard to privileging, there are special rules about giving temporary privileges, right? If you bring somebody on, you don't have to go through your whole credentialing process where it takes you 6 weeks to get them credentialed. There are special rules about it. If you want more information, please contact us, because that's just too detailed to go into right now. Okay. There are also some rules. Some of the rules have been eased with regard to not having to be face-to-face to prescribe controlled substances. Again, you have to worry about your state rules. You have to make sure that you're thinking about, when you're doing telehealth, where you're storing the information, and that it's not just, disappearing into the ether. Okay, so like I said before, you still need to document visits, right? So many times your telehealth system that you're using will not interface with the EHR. So then your providers need to go back and actually be documenting that something happened and documenting the visit. So I keep getting these questions about what you need to document. It's a visit. You need to document the typical things you would in a visit. Obviously, if you're doing it by telehealth, you're not making the person get on a scale in their house and taking their height and weight, right? But all the other things that you would normally take during a visit, all the information, background information you would ask, you still need to ask. Again, it doesn't have to be as detailed as before, but you still need to be doing the basic history and physical and getting the basic information as to what the nature of the visit is. You also need to still be, so I know we're not up to reimbursement yet, we'll get there in a minute, but you also still need to be coding, right? Telehealth is a add-on code, but you still need to be putting a CPT code in or anything else for what you're doing for the visit in order to get paid. Same way that telehealth doesn't replace the requirement to have something on Form 5A. From a billing perspective, it does not replace the requirement to document and to code. Okay, Sam, do you want to go ahead?
Sure. So we're going to move into more of a description of reimbursement for telehealth services. So you might have all heard and seen the news reports about how Medicare has loosened the standards for providing telehealth visits, and now anyone can provide telehealth. And so historically, Medicare would only pay for telehealth visits if the originating site, so the originating site is where the patient is. So the originating site had to be in a rural area, and the patient had to be in one of these facilities that was listed out in the regulations. And it was really limiting because, for most people, for most facilities, they wouldn't meet the rural area requirement. So on March 6th, the federal government passed the law that removed the originating site requirement. So the patient didn't have to be in one of these facilities, and the facility didn't have to be in a designated rural area. They allowed telehealth visit or paid for telehealth visit that is provided through audio-visual, that allowed for real-time communication, and they considered it the same as an in-person visit, and providers would be paid the same rate. The types of telehealth visits that could be reimbursed included evaluation and management, mental health, preventative health. Initially, when the waiver first came out, they only allowed this to be provided to existing patients, and I believe they defined existing patients as one that the provider had seen within the last 3 years, I think, or one provider within a group practice had seen. But then as things got worse and standards were loosened even further, CMS provided notice that we're not even going to look at whether it was an existing patient. So, disregard that requirement. They also provided the option of allowing providers to waive coinsurance and deductible requirements. So the problem with FQHCs. Oh, go ahead.
Wait, Sandy, I'm sorry. I just want to jump in. So whoever's reading these slides, by the time we send them out, we will change them. But the rule that's up here was the rule until this morning. As I mentioned, there was a new bill passed last night addressing many different things, mostly a tax bill addressing people getting some money back from their taxes. But as Sandy was talking, I was just reading the bill, and they actually put something in for FQHCs relating to telehealth. So I'm going to apologize, Sandy. I'm just going to talk about what they actually put into the bill
and
to help everyone
wonderful.
know this. And like I say, by the time the slides go out this afternoon, we'll have changed this. Okay, so if you want to get your PPS, the only way you get your PPS is if both the patient and the provider are located in a FQHC site. So if you have two sites, and for example, you have a cardiologist only comes to the site on 1st Street, but then through telehealth sees a patient on 2nd Street, that's the only time you could get your full FQHC rate. The rule until today was that for regular telehealth that's going on today, where the provider is sitting at home, or the patient is sitting at home, or anything like that, you could not get reimbursed except for like $13 for something that Sandy's going to talk about in a minute. In the bill passed last night, they have, so I don't have all the detail because it's supposed to be regulation, but what they have said, and this is very important, is that the Department of Health and Human Services is being ordered to pay FQHCs for doing telehealth where the patient is at home um, or the doctor is at home according to the physician fee schedule. So that means, I'm just making up numbers, right? So we all know that FQHCs, if you're in an urban area, you get 80% of 170. In a rural area, you get 80% of 150. So using round numbers, you get 80% of 170. That gives you $140. If someone went to a private physician office and had that visit, they probably would get reimbursed someplace in the range of $75 to $80. So whereas until today you were getting nothing, after today, subject to when they issue the regulations around it, you will at least get the physician fee schedule amount, which is probably, like I say, in someplace between $60 and $100 for that visit. So it's not fantastic. It's not your PPS rate, but it's a lot more than what you were getting until today. So I think that's significant. The other piece that they put in here, and again, I don't have detail to be able to tell it to you, is that, and I hesitate to say this to the CFOs and the people doing the budget, and please just remember that I'm just telling you what it says, I'm not making up the rule, is that any cost associated with telehealth cannot be used to help to figure out your PPS rate. So what that says to me is when you're doing your Medicare cost report at year end, you're going to have to somehow back out your telehealth costs from that cost report. How you're going to do it and what the costs are, does that mean only the equipment you bought, or does that mean the providers who spent the time doing it? I don't know the answer to, and that'll have to be clarified. But I do want to point out at least that's what is currently stated in the new law that was passed last night. Okay, so Sam, do you want to talk about the virtual communication piece?
Sure. So another option available to FQHCs is this virtual communication services. It's different than virtual check-ins that are allowed for non-FQHCs. Similar idea, but just different codes, and they call it something different. So Medicare will pay an FQHC for a virtual communication service if the practitioner provides at least 5 minutes of billable time. There's a different code, the G71. You can't submit a code using the G 2012 or 2010. Those are for non-FQHCs, and it won't be paid. Payment is set at the average of the national of the two other codes, the national non-facility physician fee schedule payment rate for the other two codes. And for last year, it was $13.69. So you can bill for this type of service if all of these requirements are met. The patient must have had a billable visit within the previous year. The patient didn't receive any FQHC-related services within the previous 7 days, and it doesn't lead to an FQHC-related service within the next 24 hours or at the soonest available appointment. That's because the intent of this is really just a virtual communication. If it resulted from a visit that the patient had in the previous 7 days, they say that payment for this call was included in the payment for that visit. And if it leads to a visit within the next 24 hours or the next appointment, they say that payment will be incorporated into your payment for that visit. So other rules about virtual communication services, right now there's no frequency limitation. So you know, if you have to call the patient 3 times based on, medical necessity, then you have to call the patient 3 times. But it's limited to certain practitioners that are listed there. Patient consent should be obtained, and that could just be verbal consent that you document in the record. It can be provided through a telephone call. You can use AV technology, or, if the patient sends a picture and you can follow up with them within 24 hours. And it has to be initiated by the patient in order to determine if a visit is necessary. So whether you need to have the patient come in.
Okay. So now we're going to get to Medicaid reimbursement. And like I mentioned at the beginning, but some of you were not on at the beginning, so I'm going to mention again. The 2 things. Number one is, if you are reading anything about Medicaid reimbursement in your state, you need to be very careful because in many states, if not most, the rules for Medicaid reimbursement for telehealth are different for FQHCs than they are for everybody else. So for any of you who may have listened to any of the webinars we gave earlier this week, I think we made clear that we were not talking about FQHC reimbursement because the rules are different. So number one is whatever you're reading, whatever you're addressing needs to make sure it's FQHC specific. Number two is that each state is different, and so we can't go through every state. We are going to go through New York and New Jersey in a little bit more detail and then mention some other ones. The main reason why we picked New York as the example is because, as I mentioned earlier, the rules in New York have changed 4 times in the last week as they relate to FQHC reimbursement. And I think that many of the issues that have come up in New York will come up in other states. So if you're in other states, it's important to listen to it. Obviously, in New York, you want to understand exactly how it works. Okay, so again, there are slides here that give you the detail, but I'm just going to give you an overview of it. New York will reimburse for telehealth and for telephone. Again, for purpose of the next 5 minutes of me talking, telehealth means that it's audio-visual, subject to whatever Sandy mentioned at the beginning, what kind of audio-visual you can, but telehealth meaning audio and visual, telephone meaning only audio. So New York will reimburse all providers, but specifically we're going to talk about FQHCs for telehealth and for telephone. New York will reimburse for these services regardless of where the patient is located and regardless of where the provider is located. So you can have a provider sitting at home and you can have a patient sitting at home, and you will be reimbursed both for telehealth and for telephone. New York will also reimburse for dual eligible. So this wasn't something that's changed over the course of the week, right? Until, like I just mentioned, until a few minutes ago, and even now, Medicare will not reimburse you regular FQHC rate for telehealth, for most telehealth services that are going to be performed over the next couple of months. Originally, New York took the position that if you have a dual eligible patient, right, dual eligible meaning a patient who has Medicare and Medicaid, since Medicare is not paying for it, you can't come to us and say we have to pay you your full FQHC rate for Medicaid because normally Medicare would have paid something for it, and therefore New York was not going to reimburse under the Medicaid program for dual eligible. New York has now changed and said they will reimburse for dual eligible. So pretty much any Medicaid patient that comes through your door, whether it's a fee-for-service, managed care, dual eligible, New York will reimburse FQHCs for the services. Now the question becomes, what will they reimburse? Right? So like I mentioned earlier, you still have to have all the records and have all the information. So let me tell you where New York is, and for those of you who are in New York, I know that you share my frustration. New York issued guidelines which contradict themselves on their face. In one place or 2 places, it says that if you're doing telehealth, again, I'm not saying telephone, you're doing telehealth, and the patient is at home, the provider is at home, you will get your full PPS rate, your full wrap rate. In another place, it says that no, you will only get your off-site rate. So for those people in other states, not necessarily does every state have it, but for just when I talk about off-site rates, so in New York, for example, you have a patient who's usually an FQHC patient, and for some reason is now in the hospital, and the FQHC doctor goes to do a visit on the patient in the hospital. So in New York, you get reimbursed for that, but you get reimbursed at a much lower rate. That's around $50 you get for that visit, whereas your full rate could be any place from $150 to $300. You're only getting $50 for it. That's the off-site rate. So at least in one place in the guidance, New York has said you will only get the off-site rate. Without boring everyone from other states too much, for the people from New York, I know that you say you're supposed to bill a 4012, that's the billing code, and you're supposed to be able to get wrapped based on your MCVR for 4012. I understand all the arguments. Right now, it's not clear that you're entitled to it. So, but for telehealth, you're getting reimbursed either your off-site rate or your full rate. Hopefully, they're going to end up with your full rate. For telephone calls, the rates are different. So what they've now said, and I can't explain to you why they've made this differentiation. What they've said is that if the phone call is with a doctor, nurse practitioner, or PA, and it's a consult over the phone, which is not being done within 7 days of a visit as a follow-up to that visit, then you can get reimbursed for it. What you get reimbursed is the same dispute as to whether that means your off-site rate or that means your full PPS rate. For other providers, like behavioral health, right? Like, as everyone could understand, behavioral health is probably going to be one of the more popular services now because people are completely panicking and need to be able to talk to someone. Right now, for behavioral health done by telehealth, you would be in the same boat of getting either the off-site rate or the full PPS. But if you're doing it by telephone, you would get reimbursed a much lower rate, which is someplace between $10 and $30, depending on how much time you're spending with the patient. Again, I cannot explain to you why behavioral health is being treated differently. I can only tell you that it is being treated differently. And when I say behavioral health, I mean anything other than actually physician, nurse practitioner, and PA. It could be a therapist. It could be any other kind of provider would only get reimbursed this $10 to $30. Now, there has been some discussion that the state may modify that to include these people in getting your full PPS or getting your off-site rate as well, but so far that has not happened. So again, in New York, you can be reimbursed for telephone visits as well, depending on what kind of person is on the phone. That could be any place from $10 to your full PPS rate. Okay, in New Jersey, again, you can do telehealth. In New Jersey, it's only telehealth, not telephone. Telehealth, again, using any of the standards Sandy talked about earlier, the patient could be wherever they want, the provider could be wherever they want. You will get your ordinary full FQHC rate in New Jersey for doing telehealth services. Any practitioner, it's not limited to doctors, nurse practitioners, and PAs like New York. It's any practitioner, you will get your full telehealth, your full FQHC rate. Again, New Jersey does not have any provision to pay, at least as of yesterday, did not have any provision to pay for telephone-only services. So if you're doing telephone only, you would not get reimbursed. I should mention that in many states, there are a variety of services being made available. So if you have, right, oftentimes in FQHCs, we have patients who don't have internet or don't have other access to be able to do telehealth. There are many services that are being made available where they can get free internet for a couple of months or things like that. Or we know of FQHCs that are providing tablets or other types of services so that their patients can be able to have telehealth at home. And, if you want to talk to us about it, please give us a call and we can talk about it in more detail. Okay. So other states, right? So in New Jersey, again, the standards can be any kind of other standards. There is some suggestion about going to telephone, but I don't think they've agreed yet that they're going to provide. You can do telephone, but I don't think they've agreed they're going to provide the FQHC rate for telephone. Again, like Sandy mentioned, you can't use the forward-facing kinds of systems. In New Jersey, they have relaxed more of the requirement for history and physical than they have in other states. But again, like I say, in each state, you need to be careful of your state. Okay, so with regard to other states, as of March 24th, there are 22 states that have talked about it. Here's a list of the states. I'm not going to sit and read through them. And here is a survey. So I will go slowly for a minute through these slides, and then we will send it out to you so you'll have it. But the question is, can you do audio only? And in many of the states, the answer is yes. And in many of the states, they actually will pay you your full rate for audio only. Again, you need to go back in your state specifically and look at it because we did this as of 2 days ago, and it could have changed since then. Okay, We have now gone over our hour, so I'm just going to mention two other webinars that we have coming up, one on Monday and one on Tuesday. On Monday, there is one that applies to employers and many of the rules that are out there with regard to FMLA, Family Medical Leave Act, special for the virus, and tax benefits that may be available to employers. That will be a presentation that's not FQHC specific, that's across the board because the rules are not different for FQHCs. That will be on Monday. If you need information, it's on our website, or you can send me an email and I'll tell you when it is. On Tuesday, Sandy and I will be doing another webinar on FTCA deeming. As I mentioned at the beginning, the application is currently due on May 14th. Even though it does not make any sense that you should have to be dealing with FTCA now and preparing the application, going through the hoops you have to go through every year because you have more important things to do. HRSA, at least as of yesterday, was still taking the position that it's still going to be due on May 14th and they're not going to push it back. So we'll be doing a webinar like in years past to walk you through what you need to do for the application and what's different this year than last year. I just remind you, and I say this with much hesitation because I know you need to worry about keeping your doors open and taking care of patients, but many of the things you need to do for FTCA are not things you could do in 2 days before because you need to have reports to your board, you need to have plans that were approved by your board, you need to show that you reported back to your board on what you did. And so given that, May 14th, that for if you have your board meetings generally towards the end of a month, that knocks out May for you. And we're at the end of March already, so that pretty much leaves April for you to do it. So I think you need to focus on it, and that's why we're doing it next week in the middle of this crisis to try to help you. We may do another session a couple of weeks later because we understand people might not be able to join because of the crisis. But if you can, I would encourage you to have someone, looking at this because you will need to do this very shortly, or somehow convince NAC, convince HRSA to push it off. Okay, so I know there's some questions that have come in. Unfortunately, we did not get time to respond to them, but we will respond to any questions, and you could feel free to send us questions separately. Here is our contact information and our emails. Like I mentioned, the slides and the recording will go out, and typically they would go out today. We have to change some of those Medicare slides that are mentioned, so they probably will go out tomorrow or by Monday, the latest. Thank you for listening, and hopefully we will speak to you again next week.